Welcome to our webinar. My name is Nikki Boyd with Sachs Healthcare Communications. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of the screen and pressing Enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. Please see your screen for the handouts and download them. If you experience technical difficulties, please use the Tech Support tab, also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC or Command-R if you're using a Mac. Please make sure you're not behind a firewall, as this will prevent you from viewing the presentation. I would like to introduce our moderator, Lexi Caraway. Lexi Caraway is currently a senior patient trainer for Hillrom and a member of the Illinois Society for Respiratory Care Board of Directors, currently serving as a delegate and also the Illinois PACT co-chair. Lexi has published several abstracts for the AARC Open Forum, including a study titled Telemedicine, Improving Quality Metrics in a Rural Community Hospital. She has presented at several local and state respiratory care conferences.
Thank you, Monica, for that kind introduction. The title of our webinar today is Mitigating Unplanned Extubation, Best Practices, Assessments, and ICU Surveillance. Speaking on this very timely topic is Justin Phillips. Justin is currently a critical care respiratory therapist at Zuckerberg San Francisco General Hospital and Trauma Center in San Francisco, California. In addition to participating in department research projects and physician and nursing education training, Justin volunteers for the RCS Department Educational Conference. He is an adjunct instructor at Alani College for Health Sciences and Technology, Newark, California, focusing on ventilator management. Justin has presented at numerous national conferences on a range of respiratory topics. The speaker has disclosed no conflicts of interest associated with this presentation. This activity has been approved for 1 contact hour of continuing education. At the end of this webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of the webinar. This activity is supported by an education grant from Dale Medical Products Incorporated. And now I will turn the presentation over to Justin.
Thank you for the warm invitation and introduction, Lexi. It's a great pleasure to be here this morning. So we'll discuss a very sensitive topic, and that's going to be the unplanned extubation in the ICU. So we'll cover things that have to do with best practices, ICU assessment tools that clinicians can use at the bedside, and then ICU surveillance, which may be helpful to not only clinical staff, but from the organization as a whole as well. So after our discussion this morning, it's my hope that you'll be able to describe common sense measures that clinicians can utilize to reduce the likelihood of an unplanned extubation. You'll be able to discuss current evidence and best practice measures focused on unplanned extubation management of our patients. And then lastly, you'll be able to explain the role of daily sedation interruptions and targeted sedation in conjunction with spontaneous breathing trials when considering unplanned extubation risk. So starting from the beginning, there's a huge interest in unplanned extubations and all the circumstances around it. For starters, as good stewards of clinical care, we want to improve patient-centered outcomes. And because of that, being able to minimize adverse events and avoid the preventable death in our patients is huge. When a patient has an unplanned extubation, some questions tend to arise. For starters, are unplanned extubations a predictor of in-hospital mortality? Additionally, if a patient undergoes an unplanned extubation event, are they at higher risk for morbidity and mortality, especially if they require re-intubation? These are some things to keep in mind. So it's not a surprise here that unplanned extubations are considered a quality of care issue. Now, they're common. And I say that with pause because depending on reporting systems from institutions across the globe and the literature that you look at, what you'll see, and we'll get into later on this morning, is that there's wide variances on reporting on how common unplanned extubations there are. But for our purposes, if you take a moment and pause and you really jog your memory, it could be last night, it could be yesterday, I'm pretty sure everyone in attendance this morning can remember the last time they've seen an unplanned extubation in the intensive care. Perhaps it's might be more common than what we think. And then lastly, it can be costly, especially when we think about unplanned extubations that are associated with reintubation and perhaps a more intense and robust form of healthcare provided after the reintubation. Well, the cost of healthcare adds up, and that's handed off to the consumer. Not all not all unplanned extubations are benign. There are some life-threatening complications that are associated with certain unplanned extubation events. They may lead to profound hypoxia. They may lead to respiratory insufficiency, hemodynamic complications, severe brain injury secondary to prolonged hypoxic events, and then death in some patients. So it's a real serious topic. There is a multitude of organizations that are focused on minimizing adverse events in patients and really centric around avoiding the preventable death in patients when it has to do with unplanned extubations. These are just a couple of the organizations that are out there that can provide great resources to clinicians and organizations that are starting to gain interest on how to improve minimizing those events in their organizations. So if we were to define what an unplanned extubation or a UE is, it could be put simply as the deliberate or premature removal of an endotracheal tube in a patient undergoing invasive mechanical ventilation. Now, under the umbrella of extubations, we can really branch out into types of unplanned extubations. So there are clinician attributed unplanned extubations, and that's going to have to do with things that we typically see as clinicians. So malpositioning of endotracheal tubes on perhaps a chest film, overinflating the cuff of the endotracheal tube so much so that it causes the actual endotracheal tube to herniate above the vocal cords. There's obviously poorly secured endotracheal tubes that will lead to an unplanned extubation. And then perhaps the one that we worry about a lot, which is dislodgement of the endotracheal tube during high acuity procedures. So things like transporting, routine bed care, and things of that nature. Now, there are also patient-initiated unplanned extubations. And these are the ones that we're very familiar to as self-extubations, dislodgement of the endotracheal tube due to violent coughing, vomiting, or patients thrashing around in bed when they're agitated. Now, regardless of the subtype of unplanned extubation, it's really helpful to understand the occurrence and prevalence of this. Now, looking at the literature and looking at numbers from our organizations can be tricky. But understand being able to track occurrences will, of course, give us some insight on the frequency and the actual rate of which these events are happening. But they will also help us assess implemented quality improvement measures, especially if you're working in a center that is focused already on trying to improve the incidence of unplanned extubations. Being able to track these things is really important. So let's talk a little bit more about occurrences and being able to track these. It can be quite tricky because I can tell you if you peruse the literature around unplanned extubation, reporting is not necessarily standardized. We'll talk about two common ways that if you were to look at the literature or look at numbers coming from organizations on how people report unplanned extubations. Okay, so for starters, the simple way to look at it is as an absolute percentage. So that's pretty simple. We take a number of events, divide that by a number of patients in a population, and what we get is an absolute percentage of unplanned extubation. That's what you'll typically see as far as reporting from organizations, and if you look at literature around unplanned extubations. Now, this can be tricky, particularly when we're talking about patient populations, patients with very specific pathophysiology that tend to lead to longer durations of mechanical ventilation. There's just some disease states where patients have to undergo longer mechanical ventilation days. So how do we account for that? Because if we think about the rationale behind that, patients who require more ventilator days might be at an increased risk for an unplanned extubation event. So in order to account for that, the second way you can look at occurrences is to take a risk stratified or look at incident density approach, okay? And that will account for variations in duration of mechanical ventilation or intubation days. So if we're looking at it from a risk stratified approach, what you'll do is you'll take a number of events and divide that by the days at risk or the days of endotracheal intubation. And that will adjust for differences in mechanical ventilation. Two different ways that are used to report the findings of unplanned extubations. But again, from a quality assurance perspective, if you're interested in tracking these things, or even at the clinician level, if you're just curious to understand the literature, being able to pull apart these two ways of reporting is extremely important. So what does the literature say? Now, if you remember from a couple of slides ago, I said it was common with an asterisk and a pause. And that's really, it has to do with reporting. Again, because of the different types of reporting, because of perhaps underreporting or not tracking at all, what we see is wide variances in the rate of unplanned extubations across the globe. But most literature will give some signal that unplanned extubations occur in ICUs at the rate between 7 to 16% as an absolute percentage. Or if we're looking at a risk stratified or incident density approach, it's 1.1 to 2.1 events per 100 ventilator days. Now, this begs a really important question. Do you know what your institution's rate of unplanned extubations is? We can't improve processes, again, if we don't know where we're starting. As good clinicians, we know things like heightened care activity, lower sedation practices, specific geographic areas in our ICUs, and weaning practices that we use all may attribute to an unplanned extubation. It's just part of critical care. When we think about the current standard of ICU care that's used from coast to coast or across the globe, there's a huge emphasis on discontinuation of invasive mechanical ventilation at the earliest feasible time. Now, we're able to do that through daily sedation interruptions, use of spontaneous breathing trials, and targeted light sedation because we understand the negative consequences of invasive mechanical ventilation. So we try our hardest to get people off the ventilator. Along that way, being able to transition patients to unassisted breathing can be extraordinarily tricky from the nursing perspective, from the respiratory therapist perspective, from the intensivist perspective, because realizing it's really going to be a balancing act and a fine line between onloading workup breathing support back to the patient, titrating sedatives, and keeping people calm enough so that they can tolerate weaning, but not too wild that we experience unplanned extubation. Everyone, I'm sure, has experienced this. It's a very fine line. Now, there are obviously unplanned extubations that do not require reintubation, but this morning, let's focus on those that do require reintubation. If we could provide great clinical vigilance and frequent reassessment for all our patients in the most optimal setting after an unplanned extubation, then yes, perhaps we can influence the need for intubation. But unplanned extubations that ultimately intubation, again, brings up a bigger conversation. Are these patients at a higher risk for mortality and complications? What is the impact of length of stay in these individuals? Now, being able to kind of forecast this ahead of time, you're going to have to at least have some form or structure as what does your organization look at for reintubation criteria. Now, this could be very simple as what you would use for a failed planned extubation. And a lot of the literature, when they look at reintubation criteria after a unplanned extubation, they use very similar criteria. So it generally has to do with a time frame. More recent literature will look at reintubation cutoffs at 48 hours after an unplanned extubation. If you see older literature, it may stretch to 72 hours. And then some change in physiologic parameters. So increased work of breathing, airway compromise, and sustained hypoxia. Now, this is a publication out of the Society of Critical Care Anesthesia, and the investigators were really focused on demonstrating through a systematic review or updating through a systematic review the current state of knowledge for clinicians around unplanned extubations. So they looked at the incidence of these events, perhaps risk factors pertaining to these events, circumstances around these events, and then how to mitigate this through what were the outcomes and what can we do as far as prevention through all the literature. What's interesting is this publication was about 10 years ago in 2012, and despite numerous publications on unplanned extubations, this goes true, this is still true today, 10 years later, there are very few studies that focus on preventative strategies for adverse events. This is a huge area of opportunity. We can understand circumstances, we can understand things that attribute to unplanned extubation events, but being able to focus on adverse events and minimizing that is huge. This really has to do with surveillance. So if the rate of unplanned extubations in your ICU is greater than 0%, surveillance can be useful, right? If you are taking a reactive approach to mitigating unplanned extubations, we really need to change our thought process and take a more proactive approach through surveillance and quality assurance. This begs the question, are you tracking or are you not tracking these events in your institution? Obviously, unplanned extubations compounded with certain disease processes can influence outcomes, but we need to be able to gather as much data behind these events in order to impact change in a positive way. Let's dive deeper into tracking unplanned extubations. So again, there are hospitals that do track and there are hospitals that don't track this information. As we get deeper and deeper into the world of healthcare, we'll see that at some point care will evolve that a lot more hospitals will want to track this information. But starting with hospitals that do not track this information, what's interesting is hospitals that don't track, or hospitals, excuse me, that hospitals that do track unplanned extubations, they may report lower incidences of unplanned extubations. And that may be attributed to the initiatives that they have in place and the quality assurance that they have in place. They just may see lower incidences of unplanned extubations because they are monitoring these things. On the flip side, when we look at hospitals that do not track unplanned extubations, there's also some issues around that. There's a potential for underreporting. You can't report what you don't know what's going on. And that also may account for lower unplanned extubation instances in the published literature. So understand that as well. Now, when it goes to tracking unplanned extubations, I can tell you perhaps one of the first hurdles that you're going to have to overcome as an organization is optimizing your electronic medical record system. Optimization of the of your EMR is key because what you'll see is out of the box, a lot of EMR systems make it very difficult to obtain quality metrics that are meaningful pertaining to unplanned extubations. This data that you want to find may be very hard to find. So out of the box, your first hurdle is going to have to be trying to optimize your EMR to track these things. A little bit more about quality metrics. Obviously, quality metrics can aid in identifying suboptimal clinical care area and areas for opportunity. That's just a part of quality assurance. It's our hope, though, through quality metrics that we can find things that have signal so that we can improve emphasis or workflow for our clinicians. We want to be able to pick quality metrics that are comprehensive, yet feasible to track. Additionally, when we outline all our areas of opportunity and we start looking at quality metrics, it may be helpful to lay out your areas of opportunity in some type of map like this. And then ask yourself, do these quality metrics apply to this roadmap? So are we picking out quality metrics that help us with instituting and tracking protocols for weaning of mechanical ventilation, looking at weaning readiness criteria? Do we have sedation protocols for nursing, and how does that fare? Are we tracking things that have to deal with nurse to patient ratios? Are we looking at metrics that provide some signal to high acuity procedures such as transport, patient supervision, things of that nature? Keep that in mind as you're trying to build your surveillance program. This is a publication done in 2007 in the Journal of Critical Care Medicine. And it's helpful, especially if you're in a smaller organization or an organization that just doesn't track these things to begin with. It can really give you some insight on what quality metrics you should look for. Now, this wasn't in particular to unplanned extubation, but you can take their formula and apply that to tracking things that have to do with unplanned extubation. If you can forgive the very small print here, but it really breaks, the investigators really broke their process down to being thoughtful, methodical, and always involves follow-up. When they picked out metrics, they looked at things that had to do with structure, again, the infrastructure. So what was the availability of, for the example of unplanned extubation, what was the availability of intensivists or trained anesthesiologists or someone who can intervene after an unplanned extubation? What are nurse to patient ratios looking like on a specific day of the week? When we have to deal with things that have to deal with process, what are length of ICU stays looking like for individuals that have unplanned extubations? Duration of mechanical ventilation, things of that nature. And then lastly, outcomes. We want to know what to do after this data so that we can improve patient care. What were the outcomes in this patient? So look at disease severity, date of discharge, the total number of unplanned extubations that were experienced, things like that. Some other measures of interest that I didn't talk about on the previous slide that may be of interest are, again, what is the status of the patient at hospital discharge? Were they restrained during the time of the unplanned extubation event? What type of restraint was used? The ability to communicate, or the ability of the patient to communicate at the time of the unplanned extubation might give you some insight on level of mental status. The unplanned extubation mechanism behind the event. Okay, age, gender, intensive care unit setting. We all know geographically in the hospital, some areas have higher acuity than others. That may open the door for unplanned extubations in some parts of the hospital. Okay, event day. Are there certain days of the week that are less staffed? Are there more higher acuity procedures, transports, things of that nature? Again, areas of opportunity for these events. You want to be able to identify these things through your surveillance metrics. And then if you don't have a pre-established predictor suggestion or guideline for clinicians for reintubation after failed planned extubations, perhaps we should establish one that we can use for both failed planned extubations, but the failed unplanned extubation. And this, I understand critical care can be very fluid, and clinical judgment is always the deciding factor when it comes to reintubation, but this can be very helpful for junior staff, junior respiratory therapists, nurses, physicians to kind of formulate where this picture is going. And the screening criteria can be as simple as, well, what is their mental status in terms of RAS or GCS? What was the robustness of the mechanical ventilatory support that they were receiving prior to the unplanned extubation event? What did their gas exchange look like via ABG analysis, PF ratio, things like that? So having that in mind, and having that as somewhat of a guideline and standard can be very useful so that we're not having all these sideline conversations at the time of an unplanned extubation. Let's talk about reducing the likelihood of an unplanned extubation. As I said before, critical care is very fluid. It's a changing and dynamic environment. We all know that. There are unpredictable clinical circumstances, and sometimes we hit the ground running at the beginning of our shift and we keep going to the end of our shift. And very common sense measures sometimes go out the window, or it becomes second thought. So I want to talk about common sense measures that we need to continue to keep in the forefront of our memory while we're providing high-level patient care. And that has to do with routine evaluation of things like endotracheal tubes. Again, I know it sounds very common sense, but monitoring tube placement can be super key in minimizing tube dislodgement. A little bit more about threats and vulnerabilities in our processes. So obviously, securing devices, whether they're traditional methods, commercial methods, they all have device failure points and stuff like that. And we need to be aware of these things, and our staff needs to be aware of these things. Other vulnerabilities, transports. If anyone has been on a transport with a mechanically ventilated patient on tons of drips, we know there's tons of room for tube entanglement, line entanglement, things getting pulled. Another area of vulnerability. High-risk procedures. In the times of COVID, there's a lot of prone positioning utilized across the globe. Prone positioning can be very dangerous as far as the tube placement per se. It's a high, it's as of now, it's still a high acuity procedure where there are parts of the procedure where the tube may not be visible to clinicians. There's lines that are being pulled. So routine bed care is another area of opportunity or vulnerability. Mobilization and early mobilization with like physical therapy is obviously needed in critical care, but it is an area of vulnerability, particularly with intubated patients. Okay, and then things that we can avoid: high census, inadequate staffing ratios, keeping these things in mind, threats and vulnerabilities for the unplanned extubation. So what are the physics behind remaining intubated? And it's really simple. It's just a tug of war, really, and it has to do with force and displacement. So displacement force, the angle of which the force is applied, relative to the force that's being applied by the securing mechanism, okay? So in order to remain intubated, really the force applied by the securing mechanism just really needs to overcome displacement force and the angle of force applied. And that goes in any position, whether they're supine or they're in the prone position. This is a publication in some biomedical engineering research, which is quite interesting. The investigators evaluated tube motion and device failure. And device failure is essentially failure in a securing device to the point where it allowed for what would have been an unplanned extubation. And it really confirms this thought process that unplanned extubations and tube migration is really dependent on the angle of which the force is applied, the amount of force that is applied relative to the countering force of the securing device. Now they simulated self-extubation, extension, entanglement, and all of these things that we see from a day-to-day basis. Let's talk a little bit more now about endotracheal securing devices. And right now, we'll talk about the commercially available devices. So commercially available endotracheal securing devices are great from the perspective that they have a very low threshold for training, right? There's not a great learning curve. Everyone can apply them. As far as skin breakdown is concerned, they're nice because they allow for frequent readjustment, easy assessment. They can be universally applied. These things are made from a lot of manufacturers in multiple sizes, from pediatric to multiple adult sizes. So they're nice from that perspective. We can also look at securing devices that maybe are less common in 2022, although they're still utilized, okay? And while they can be called other securing devices, they're more or less traditional methods. So taping endotracheal tubes, twill ties, if you're still using those. I know there's institutions that are still utilizing them, particularly for like burn patients and somewhat. So the difference between these and like a commercially available endotracheal tube holder is, well, although they're universal as well, right? You're only limited to the length of tape that you have or amount of twill tie that you have. They could be customized to the specific needs for your patient. But if you are used to using commercial securing devices, there could be a huge steep learning curve associated with other securing devices. It could be quite tricky to secure an endotracheal tube with tape, especially if it's been a very long time since you've done it. Additionally, unlike commercial tube holders, using traditional methods like tape and twill ties generally fix an endotracheal tube to one position. So there's a higher incidence in some patient populations for skin irritation, breakdown, because we cannot reposition it. Let's transition now into talking about the importance of unassisted breathing so that we can minimize the unplanned extubation. This is really going to have to deal with using standardized spontaneous breathing trials, standardized weaning readiness criteria, and frequent assessment for weaning readiness. The rationale behind this, again, is there are some patients that undergo mechanical ventilation for whatever reason, but the underlying disease process or mechanism is resolved quite frequently. And depending on acuity census or the day of the week, sometimes these patients aren't weaned. It's ideal to be able to screen these individuals, get them to the point where they can be assessed by the final decision maker. So whether that's an intensivist or an ICU doctor or whoever, essentially what we want to do is expedite care in those who meet weaning readiness criteria, get them to the point of assessment by the final decision maker so that we can have a planned extubation, so that we don't have individuals hanging around on very low mechanical ventilatory support and open the opportunity for an unplanned extubation. So I could give you a little insight on our organization's way of how we transition people. This is a screenshot of a survey that populates in the EMR flow sheet for both nursing and respiratory therapy every time someone is committed to invasive mechanical ventilation. And it goes through very specific questions pertaining the circumstances for that individual at that point in time. So it asks very specific questions about the level of sedatives and analgesics. Have they had a daily sedation interruption? If they've had a DSI, what is the outcome? It asks some very specific questions about the underlying pathophysiology requiring mechanical ventilation and a little bit about their mechanical support. It asks them if they have been started on a spontaneous breathing trial, and if they have, what is the outcome? If they haven't, why haven't they? And have providers been notified, especially if someone has been passed on a spontaneous breathing trial? So again, we can get them to the point where they can have a planned extubation rather than hang around on the ventilator and have an unplanned event. Here's a little bit more finer detail of the specific questions that the staff, the clinical staff, are answering when they fill out the survey. So I can tell you at San Francisco General, we instituted a standardized weaning practice for both mechanical ventilation through a standardized spontaneous breathing trial, and we also standardize weaning practices for daily sedation interruption, sedation back in 2008. And since then, we've been able to slowly decrease the days of mechanical ventilations in our patient population. Okay, we're able to get those that met weaning readiness criteria to the point of planned extubation sooner. Again, getting them to the point of planned extubation sooner may help you minimize the amount of unplanned extubations that you have, particularly when patients are awake enough with low enough sedation. I could tell you from personal experience as an educator at our institution, it can be very tricky convincing staff, especially junior level staff, to use the tools that we have to empower them when it has to do with weaning sometimes, especially with junior level staff and they see people intubated 1, 2, 3 days ago. It's very hard sometimes to convince staff that you should progress care in terms of weaning, especially if they meet if their underlying pathophysiology is resolved and they meet weaning readiness criteria. We really need to move the ball forward so that we can avoid the unplanned extubation. I could give you some data from our institution. So this is out of our medical ICU. So when we implemented, again, the standardized spontaneous breathing trial, this is looking at the number of SBTs required to pass SBT. We have a time frame of 30 minutes to 2 hours in our organization, and we consider that a pass at low level pressure support. Okay, and what you can see is on day one, when patients met weaning readiness criteria, the pass rate for a spontaneous breathing trial was well over 50%. If we look at cumulative days after that, that's going to be in yellow. Subsequent days, pass rates for SBTs only increase. Okay, again, being able to screen people and getting them to a planned extubation is important. We observed very similar data in our surgical ICUs. On day one, when patients met weaning readiness criteria, well over 50%, 70% of these individuals passed an SVT on their first trial. On subsequent days, that's going to be in purple, you can see, again, it's only improving from that point. Excuse me. Okay, so remember I said we implemented standardized weaning practice back in 2008. So 10 years later, our organization remained committed to looking at unplanned extubation still. And this prompted a few of my colleagues to look at retrospective quality assurance data from our electronic medical record system. And we also have an institutional-wide standardized or central reporting system for what we call UOs, or unusual occurrences. So they're able to pull data from those databases to give insight on basic demographic information, primary diagnosis, mechanical ventilation data, sedatives, mental status, reintubation rate, and patient status at discharge. Because we were really curious on how our initiatives fared 10 years later. Now, this wasn't to toot our own horn, but again, we were really interested in understanding the impact of unplanned extubation events on our patient population. Additionally, we're very interested in understanding the incidences of these events and the characteristics around them, or the circumstances around them. And we wanted to see if they were consistent with those that are in the published literature. Now, this was done over the span of 4 years, and we were able to pull data from about 98 unplanned extubation events in 95 subjects. And the prevalence was 2.3%, or the occurrence of an unplanned extubation in this time frame, 2.3%. If we looked at it at a stratified approach, that's 5.7 events per 1,000 mechanical ventilator days. Now, if we look at the more granular data that has to do with these 98 events, 91% of them were tension. They were initiated. Okay, these are the self-extubations. 6% were inadvertent detailing, coughing, vomiting, things of that nature. And then a smaller percentage was actually attributed to clinicians. So endotracheal tube malpositioning, and whatnot. If we jump down to the bottom, what's very startling here is 93% of these cases, the individuals met weaning readiness criteria. So of these 98 events, 93% of them, these individuals met weaning readiness criteria. Again, what we want to do is be able to screen individuals, get them to the point of a planned extubation so that we can avoid an unplanned extubation, or at least get them to the assessment point so that we can have a greater discussion with the care team of maybe this patient does need to remain intubated, but how do we keep them safe in the interim? And then lastly, less than 40% of these individuals required reintubation within a 48-hour cutoff. If we look at the further context of these specific events, a little over half of them, again, were with no care. These were, again, the unplanned extubation that was due to self-extubation. So unsupervised patients, what have you. About 32% of unplanned extubation events occurred during spontaneous breathing trial weaning. A smaller percentage were concurrent with DSIs and spontaneous breathing trials, and a very small percentage were done during procedures or a combination of DSI and SBT with procedures. Now, we looked at a 24-hour snapshot with this data to give us some insight if there's any signal that points to certain hours of the day that maybe unplanned extubations are more prevalent in. Okay, and what we found in this data is that there are actually, based on our organization, and it may be useful for you to go back and look at your institution and ask these very similar questions. So based off our data, just to give you a little background, we are a large level 1 trauma center that's located in the metro San Francisco area. So very busy institution. And there's quite a few ICUs here, and the nursing staff and the respiratory therapist staff are fantastic at being able to provide great level of patient care. But nonetheless, we still have unplanned extubations. And what we found is that there are heightened times of the day. So between 8 a.m. to 11 a.m. And if we think about what's going on in those times, those are generally times where there's patient handoff, nurses shifting over to the next shift, same thing with respiratory therapists. Perhaps the oncoming shift is doing assessments of multiple patients at the same time. There may be a lot of high acuity morning procedures going on. Those tend to be between the hours of 8 and 11 a.m. tend to be a very vulnerable time for us. Very similar at the nighttime hours between 11 p.m. and 3 a.m., we've seen a very similar phenomenon where there was an uptick in unplanned extubations, again, due to admissions or a lack of staff on the floor due to breaks. Now, if you're curious of what light and targeted sedation looked like in the individuals that had unplanned extubations, they were targeted to a RASS of 0. Over 70% of these individuals had some form of IV sedatives, and over 50% of these required some type of opiate analgesic. Now, at this point, if you're asking yourself, Justin, what about those that failed after an unplanned extubation and required reintubation? What did they look like? Well, put simply, they were older, they were sicker, with the majority of them having ARDS as the primary diagnosis, and over 50% of them developed signs of respiratory distress or hemodynamic instability within the allotted time frame. If we look at very specific mechanical ventilation data for these individuals preceding the unplanned extubation event, what we see is there was no difference of the mode of mechanical ventilation. There's no difference of the fraction of inspired oxygenation or oxygen, excuse me. There's no difference in minute ventilation demand or oxygen saturation in these individuals, with the only signal hinting that patients who had an unplanned extubation that required reintubation were sicker, being a difference in PEEP. Now, again, we did this post hoc analysis 10 years later as a QA initiative because, again, we remain committed and we still remain committed to minimizing unplanned extubations on our campus and providing care in a way that prevents unforeseen death in our patients, okay? Now, we are very happy to find that within this study's time frame, the amount of unplanned extubations were low. Now, this, again, is not to toot our own horn, but to help us better improve our processes. We're also very, very happy to find that our results are falling within what is reported in the literature. And we attribute a lot of this probably to the standardized weaning practices for mechanical ventilation and nursing, being able to provide and empower our staff from the nursing end and the respiratory therapist end. 10 years in the making, we're very happy with these results. So this brings me to my last conversation point, and it's best practices. How can we implement best practices from an institutional perspective? Now, we can really divvy this up with best practices for clinicians and best practices on the operation end. So let's start with best practices for clinicians. Okay. Again, it sounds very silly, but common sense measures like assuring proper endotracheal tube depth, confirming that placement routinely on chest films is important. It is a huge vulnerability, and it's a very simple step that we can take. Having an organized way to report tube depth is also important. What's interesting is even in 2022, within an organization, you will still see variances between clinicians, between the physician to nurse to respiratory therapist and everyone in between on how we report tube depth, whether it's at the teeth, incisors maybe, the lip, gums, what have you. We need to have a standard of how we report depth, because obviously that can influence whether or not we know the tube is migrating, especially when we think about things like severe facial trauma and stuff like that. Having an organizational standard for tube depth reporting is really important. Monitoring endotracheal tube during a heightened activity and doing it routinely. I think we already monitor endotracheal tubes during routine assessments, and we probably do that even during heightened activity and bedside procedures. But being able to build a culture that routinely does it pre, peri, and post procedure so that we always have eyes on placement is key. And again, the unplanned extubation. Picking a standardized and optimal securing method for your endotracheal tube is important. Now, what standardized and optimal means, it doesn't mean go out and buy bulks of commercial tube holders or commit solely to a traditional method of securing your endotracheal tube. Standardized and optimal means having a methodic laid out plan on how you're going to apply these devices on your patient population. So I can give you some insight on our institution. We use both the combination of traditional methods of tape and commercial tube holders. But we have very clear guidelines on how we use one over the other. Commercial tube holders are used for the bulk of patients requiring mechanical ventilation because, again, it allows us for easy repositioning, it might minimize the amount of skin breakdown on the lip, and it's quite convenient, low threshold for training. Great, but there are very specific instances in patient populations that we have chosen to use a traditional method for, and that's severe head trauma, where not all commercial tube holders may secure a tube on the patient's face, or there might be room for swelling. Prone positioning, we often use a traditional method, and patients that don't necessarily fit a commercial tube holder. Whatever it is, figure out what standardized and operational means for your institution. Again, this goes without saying, but ensuring adequate sedation and staffing during high-risk procedures. This is a time where health is extraordinarily lax and having available clinicians is tough. So taking steps in the right direction in providing adequate sedation is important. Having metrics that track and survey unplanned extubations is important as well. We can't move forward unless we understand where we currently are. Debriefing after events is widely accepted in critical care medicine after code blues, sentinel events, things of that nature. Integrating those things in your practice after unplanned extubations can really help staff understand the circumstances around the event and can help them move forward. Now I want to talk about operational best practices. So operational best practices can be really parsed in a couple of ways. So for starters, if we want from an operational perspective, if you're a leader in your organization, what you need to do is build a culture of safety. Establishing a common goal is important. Being able to have multidisciplinary teams on a surveillance team to help. So this includes risk management, physicians, nurses, respiratory therapists, having all these people together, again, to come together to build a culture of safety, have your common goal, and really minimize the unplanned extubation is important. Okay, developing a standardized way to collect data is important. So again, this is going to have to deal with really focusing on your electronic medical record system and optimizing it in a way that it collects this data. And then your hospital leadership, okay? As a leader in your institution, you want to present information to the staff, the committees that are involved, and again, help build that culture of safety, empower staff so that they know the rates of unplanned extubations in their institutions. And that is very important. And then these last things, again, root cause analysis or debriefing, use those things to your benefit, okay? Empowering staff, empower staff through constant training regarding the unplanned extubation, protocols and weaning practices, and then technological workflows. And I'll turn it over to Lexi at this point. Thank you for your time this morning.
Thank you, Justin, for that very informative presentation. And now I would like to go over how to obtain your CEs with everyone. This activity has been approved for 1 contact hour. You can obtain those continuing education credits by logging into www.saxtesting.com/P. You will need to register on the site and complete the evaluation form. Upon successful submission, you will be able to print your certificate of completion. This activity is supported by an education grant from Dale Medical Products, Incorporated. An archive on-demand version will be available on www.perspectivesinnursing.org. An email will be sent to all registrants when it is available. This on-demand version will be accredited for CEs. And now we have time for a few questions. If anyone is still wanting to ask Justin a question, go ahead and type it in the box and we'll see if we can get to it. Justin, first question I have here from Kevin. Is there a level of PEEP that you have in mind, say, if you have an unplanned extubation and you're just like, go ahead and reintubate rather than let them have a chance on rescue NIV? Is there a certain level that you would just go ahead and reintubate?
So I think this is a very interesting question from the perspective of how intensive cares operate. Although there is great literature on the use of non-invasive therapies, whether it's non-invasive ventilation or high flow therapy, I think as a critical care community, for the broad perspective, obviously there is some physiology where non-invasive ventilation, such as severe COPD exacerbations, actually might be beneficial. But I think broadly speaking, it's very difficult to say who should get non-invasive ventilatory support after, and what should that look like.
Okay, perfect. Thank you. We have another question. How much training do you do with staff on these unplanned extubations? What kind of preparation and staff training do you do?
So let's start, you could break this up in a couple of ways. So starting from new employees go through at least from the respiratory therapist perspective, I can speak on, they go through an 11-week training program. A big portion of that has to do with protocol management. And a lot of it has to do, whether they realize it or not, we're really prompting them to understand the importance of unplanned extubations through the training of using standardized weaning readiness criteria. So they're out of the get-go, a lot of staff are already primed to understand how to get people to weaning readiness criteria. For ongoing staff, it's usually through like annual education.
Perfect. Thank you. Have another question here. Do you see telemedicine or any of the EICUs, do you see that helping the situation, or is it better to have practitioners in the room?
I think in the landscape of healthcare today in 2022, the importance of telemedicine is huge. So I don't discount what it has brought to the table. I'm not entirely sure because I don't have great experience in telemedicine. We're a large academic medical center, and we have the luxury of having multiple services on campus around the clock. I think, yeah, there may be some influence, particularly, I don't necessarily know how telemedicine is staffed from an intensivist perspective, but if you're trying to implement standardized protocols that have to do with weaning to get people to the point of a planned extubation, I can see that potentially being a barrier to overcome, especially if you're using a telemedicine situation where you have like per diem staff.
Thank you. And another question we have here is, how has COVID impacted these unplanned extubation rates with practices such as proning?
So with specific to COVID, it's very difficult to tell at this point. I think it's what you'll hear are just case reports of what's going on in our ICUs. We don't have definitive data since our 2018 study. This will be in the pipeline for ongoing quality assurance. We do have like quarterly quality assurance committee meetings with the broad spectrum of critical care. This includes all topics of quality assurance, not just unplanned extubations. So I'll be very interested, especially as we start to kind of go back into the conference rooms, because we've not really been in the conference rooms for the past 2 years, and we begin to have broader discussions on workflows. These are questions that hopefully we'll be able to answer in the near future.
Okay, wonderful. So that is all the time we have for questions. Thank you everyone for attending this webinar, and I will now turn it back over to Nikki for some concluding remarks.
Thank you for attending this webinar. Immediately upon conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open. We appreciate your feedback. To obtain your CE credits, please visit www.saxtesting.com/P. Register at the site and complete the evaluation.